Hi, I'm Dr. T. S. Chandrasekar, Chief Interventional Gastroenterologist, Med India Hospital, Chennai. I have great pleasure in introducing Dr. Manoel from Brazil. He is the world-renowned bariatric endoscopy therapist. Dr. Manoel, welcome to India.
Thank you very much, TSC. It's a pleasure and an honor to be here among you.
I'm impressed by the work you have done it in work related to obesity.
Thank you.
Do you think obesity is increasing or just we are diagnosing more, awareness is more?
Unfortunately, by any measures we take, obesity is a worldwide growing epidemic. It's the epidemic of our century.
So it's growing.
Indeed.
What is the reason for such amount of increasing incidence of obesity all over the world?
I might say that we are paying for the progress of the mankind. So our lifestyle, the way we have defeat the hungriness is where with bad food and our lifestyle that prevents us to do exercise and to eat well. And this among hundreds of new variables that contribute to this epidemic.
So the plenty of food, lack of exercise. Do you agree with that? Many people think that obesity is not a disease. They don't even know that obesity can produce such amount of problem.
I have to firmly disagree with it. So obesity is not just a disease, but this the worst disease of the mankind now.
Okay.
It's a chronic, evolving, and progressive disease that by the standards today, we have no cure. We can control it. Like any other chronic disease like diabetes, like hypertension. Oh, by the way, this is obesity that causes hypertension, diabetes, and fatty liver.
So if you have obesity, you get so many other diseases.
Indeed.
I used to tell jocularly, if you buy one, you get many things free.
Yes, at least 160.
Yeah, even increase instead of cancer also.
You see?
And colon cancer, pancreatic cancer, and other things also.
Yeah, and it's very unfortunately that still people that not qualify obesity as a disease, and we're seeing that disaster in front of our eyes, and even our governments are blindsided to that.
So how do you maintain your weight like this?
Well, first, I don't eat that much.
Even how tasty?
No, I try to control myself, and it's not easy.
I think that is the most important, that controlling mechanism is lacking. And I've seen people who are very obese, they have kind of eating a spree, they go into that.
Yes, and it together with the lack of exercise and lack of have good sleep, that's a lot of things.
Binge eaters, when they see the food, they start eating.
And it's our lifestyle. Easy because we stay in front of monitors, we work just sitting, this is our lifestyle on that.
So that means, you mean to say that diet and exercise, how reliable in management of obesity?
Well, we grade obesity by using a very imprecise variable that we call BMI. And it is different among the worlds. Like here in Asia Pacific, it's different from the Occidental part. In Occidental, you have 35 BMI with comorbidities or 40 BMI over. Here in Asia Pacific is 27.5 and then 32. We have to consider that because specifically for Asia Pacific, obesity is much more harmful in terms of at the lower BMIs, the patient get more diseases.
So to some extent, diet and exercise may be useful, but a higher the BMI, I think diet and exercise alone will not suffice.
Indeed. When we get and reach what we call morbid obesity or severe obesity, only surgery by our standards can correct that.
Are you a surgeon or endoscopist?
Well, I'm a surgeon. I'm a gastroenterologist and I'm a surgeon with formal education in 3 specialties.
So you will be a little biased for surgery for obesity, or what are the problems related?
The problem of surgery is, first is the reach. So just 1% of the people or patients that qualify to have bariatric surgery actually has it. So the penetration rate is just 1 to 2%. And among the reasons is economic, But most of the reasons that people don't recognize obesity and morbid obesity as a disease, a severe disease, and they are afraid of the surgery.
So they are afraid of the surgery because of complications.
Yeah, it's a general concept. You are afraid of surgery, I'm afraid of surgery, but we have to
But if I
understand
have a
it
good
more.
surgeon like you,
Yeah, I have to say that bariatric surgery is very safe.
very
It's
safe.
very, very safe. As safe as a surgery for cholecystectomy for the gallbladder. So the general public should not fear that. It is safe and is proven that is the best treatment for severe obesity patients.
Endobariatric therapy, endoscopic treatment for obesity is going to take over surgery, or both will have their own their role.
I think that both going to have their space. So what we see bariatric therapy right now is for lower BMI patients, for the ones who not qualify more for the clinical treatment, but they don't qualify for surgery. So we are talking about BMI 27, 37, 40 on that, and that gap is empty. So we basically don't have any therapy for those lower BMIs on that.
So the lowest BMI, I mean the BMI is slightly in the higher side, but on the lower side, you go for diet and exercise.
Exactly.
And highest BMI, you go for surgery. In between, there is
A gigantic gap
gap where endotherapy can be fit into the
is our vision.
vision.
Is our vision.
Do you recommend balloon? If so, whom?
Well, balloons is here among us as a clinical treatment for obesity for the last 20 years. Okay, so it's here to stay, and we definitely use balloons for the lower part of BMI when the obesity is not that prevalent, or you jump for the more severely obese, and then we're gonna bridge those patients for surgery. So that's where you see balloons. And then the new therapies like the endoscopic sleeve gastroplasty is for BMIs a little bit higher, but not as high as surgery. So with that, we're gonna have like a stepwise approach for this chronic disease that is obesity, like we have for diabetes, for example. Each step of the disease.
You mean the oral hypoglycemia, diet, oral
Exactly.
hypoglycemia, insulin plus then oral hypoglycemic agents, something like that, akin to that, no?
That's a very thoughtful approach.
So diet and exercise, maybe balloon, then you go for endoscopic gastroplasty. After that, surgery. This is how you approach it.
Yes, and you have to put on this equation the new drugs for obesity and for diabetes, and they have action on obesity. So maybe diet, exercise, medications, endotherapies, surgery, and fluctuating among these is the plus. Is endotherapy plus medicine, surgery plus medicine. With that, we will perfect our approach.
What do you mean by medicines? The pharmacotherapy for obesity or for the metabolic syndrome?
It comes like together. You see, like the GLP-1 analogs, they do so good for the diabetes, but actually they control very well the obesity, and they are being proven with studies we are doing in US, in Europe, in Asia, that if you add this GLP-1 analog, a new class of drugs in endotherapy and even in surgery, we can control that.
What about a specific pharmacotherapy for obesity, early sector?
Yes.
What is your opinion about that? You try for a long term or short term?
My opinion is that they are improving. So the problem with the pharmacotherapy for obesity is some of the drugs that was introduced on the last decades, they've proven to do harm, some of them. But they are changing for like GLP-1 analogs, the new association of FEMFEM. So there is new drugs, and they can be used again. They are designed to be used chronically on that. But the problem is that alone, they've proven that this is not enough. So that's why the new trend is to get to a middle ground that we can use combined therapies.
So where do you place that sleeve? A duodenal barrier sleeve.
Oh, like we're talking.
Is it available in the market right now?
Yes, we're talking about the endotherapies for metabolic conditions.
Yeah.
So those that we deal with the bowel, they still experimental. So they are available among trials. And the good news is that at least 2 of them are in US right now doing the FDA trials. So when they complete that, they will be available for the public. So if you wait 3 years, 4 years, they're gonna be available for us.
We are being told that duodenal mucosal resurfacing, if it is really available, it is going to work out. That will solve everything. You may not even need surgery or endotherapy. What is your opinion about that?
I think we're not gonna reach that far, but definitely we're gonna contribute a lot for the field. It's a very disruptive concept that you ablate the mucosa of the duodenum. We have a benefit and an impact on that. And I can tell you that the preliminary results are very, very promising. And we're even thinking further. So after doing the ablation, we will be able to inject stem cells that we collect in the ileum to populate the duodenum and transform the duodenum in a factory of producing GLP-1 and extend the durability.
So if the mucosal resurfacing is going to work out, be endoscopic and the surgeon will be run out of business?
I don't think so that it's gonna be that early, but in the future, I think we have to go there. If you look at the cardiology interventions, so there was a golden era of open surgery. What we're seeing right now is the golden area of the endovascular. So every chronic disease that have a surgical intervention, we see that it downgrades to endoluminal or endovascular or things like that.
What is your, have we discussed about the surgery, endotherapy, diet, exercise? The final word, most important, prevention. What is the practical tip you would like to give?
The practical thing is understand obesity as a disease. So if you have like a mandala, you're gonna see that you have to assess the disease and then you have to intervene in disease. And the disease is so chronic that after you intervene effectively, you have to maintain the weight.
Maintain.
And even more, you have to prevent the weight loss to recur.
So maintenance is the mantra.
Mantra, exactly.
So very important. Understand obesity is a disease. Maintenance is the mantra. Prevention is the key if you don't want to undergo any of this procedure. And we have just interviewed the world best man in the treatment of obesity, Dr. Manoel. He's come from all the way from Brazil, attending this wonderful APW conference. We are delighted to have met you.
Yes, it was my pleasure and honor. Thank you very much.
Thank you.